All right, this is chapter 11, the airway management chapters. Pretty crucial chapter for the advanced EMTs. This is where we'll go over the intratracheal intubation, also your review on blind insertion intubation. Also, I'll give you a little bit of my quirks about airway, but you need to be comfortable in what you're doing, um, and make sure that you document appropriately as to why you were doing what you were doing. Here's all your EMS education standards, and we'll review some airway anatomy, the assessment process, and the techniques of ensuring you have a patent airway. Pulmonary ventilation, oxygenation, respiration, external, internal cellular level. So we'll go back through all that. All right, the most important steps in caring for any patient are obtaining and maintaining a patent airway and ensuring that the patient is breathing adequately. So oxygen reaches body tissues and cells through breathing and circulation. One of my sayings is if you don't have an airway on a patient, you really don't have a patient. So if you can't gain control of it and maintain it, you might as well not even have a patient there in front of you. So being comfortable with this, it's going to take time, but it is something that you can obtain. A lot of coaching when it comes to airway patients. All right, so the airway is divided up into the upper and lower airways. It allows us to breathe and to ventilate. Okay, so you got the diaphragm, then you got the muscles of the chest wall, the accessory muscles of breathing, and the nerves from the brain and the spinal cord to those muscles. And then ventilation itself is the exchange of air between the lungs and the environment. Okay, and this is just a breakdown. Your nasopharynx, your nasal airway passage, here the oropharynx back to down to your mouth, epiglottitis, then the larynx itself that leads down into the trachea, and it bifurcates at the corona. Always keep in mind that this right one's a little bit straighter than the left, and then you branch out into your bronchioles, into your alveoli. Okay, you got all your ribs here, and your diaphragm muscles in between. So then that breaks down into your pulmonary capillaries where that exchange of CO2 and O2 take place around your alveoli. And one of our main jobs is to keep those alveoli open and keep them available so that they can be used to help with that exchange. Okay, the major function is to warm, filter, and humidify air brought into the body. Okay, so the pharynx is composed of the nasopharynx, the oropharynx, and the laryngopharynx. Okay, and there's the different parts there. And then there's a cross section there, the nasopharynx, oropharynx, and the laryngopharynx on to the right. All right, it's formed by the facial bones divided by the septum. It's lined with ciliated mucosal membrane. And then you got your sinuses there. The oropharynx is posterior to oral cavity. You got your epiglottitis, your epiglottis, which is your leaf-shaped cartilage flap located at the base of the tongue and above the larynx. All right, this cricothyroid membrane here, you got the thyroid up on top, and then it goes down into the cricoid cartilage, and then what I call the valley of death. That'll be pretty instrumental if you continue on to your medic. So, all right, the functions of the lower airways to exchange oxygen and CO2. Anytime the CO2 gets abnormal, your homeostasis within the body goes into effect, and we, either we increase respirations or we increase something to try to get our body back to homeostasis. All right, then you got your trachea, it's the conduit for air to enter into the lungs, and it's divided at the level of the corona where it bifurcates. All right, and this is just a picture of that. Remember that your trachea's got the rings on the inside. Those are pretty significant when you're trying to pass that advanced airway. We'll talk about that. All right, each bronchus divides into smaller bronchi, then bronchioles, and then the bronchioles branch into the alveolar ducts. All right, the alveoli serve as the functional site for the exchange of O2 and CO2. Our oxygen diffuses the lining of the alveoli into the capillaries. That surfactant is pretty important. We'll learn that probably in the next chapter about when that surfactant dries out and why it dries out, and how we kind of help that. But it does help the surface tension of the alveoli to expand. Okay. When the surfactant is not there, the alveoli collapse, which causes the hardening of the lung. All right, between the lungs is the mediastinum, and it's surrounded by a tough connective tissue. It contains the heart, the great vessels, the esophagus, the trachea, the major bronchi, and many nerves. The phrenic nerve innervates the diaphragmatic muscle, allowing it to contract. All right, the respiratory cardiac system work together. They ensure that a constant supply of O2 and nutrients go to every cell, and they ensure that CO2 and waste products are removed from every cell. And to make sure that we have a significant external ventilation and perfusion are required to deliver adequate oxygen. So at 0 to 1 minute, our cardiac tissue and cardiac muscle becomes irritable. 0 to 4 minutes, brain damage is not likely. And then at the 4 to 6 minute, brain damage is possible. All right, ventilation is the process of moving air in and out of the lungs. Inhalation is an active muscular part of breathing. It allows air to enter into the body through the mouth and the nose and moves to the trachea. And then the diaphragm and intercostal muscles contract and the lungs fill with air. So the ability of the lungs to function properly is dependent on the movement of the chest and the supporting structures. Okay, so if we have damage to this chest area, to the thorax, the thoracic cage, maybe the ribs are broke, the diaphragm, maybe it's herniated, or we have been using our recessive muscles a whole lot and they're starting to tire out, that's going to cause movement problems as far as the supporting structures of the lung. The diaphragm is a specialized skeletal muscle and it functions both as a voluntary and involuntary muscle. All right. Partial pressure is the amount of gas in air or dissolved in fluids such as blood. It's measured in millimeters of mercury, and the body attempts to equalize the partial pressure, which results in oxygen diffusion across the membrane into the blood. Atmospheric pressure is normally higher than the air pressure within the thorax. So during inhalation, a slight vacuum is created. Gases such as oxygen will move from an area of high pressure to an area of low pressure until the pressure equals out. And the entire process of inspiration is focused on delivering oxygen to the alveoli. So these variations in tidal volume, respiratory rate are both will affect minute volume. Exhalation does not require muscular effort. The here and rear reflex is a feedback loop that prevents overexpansion of the lungs by terminating inspiration. So relaxation of the diaphragm and intercostal muscles increases intracoronary pressure. And when the size of the thoracic cage decreases, air in the lungs is compressed in a small space and increases air pressure. So maximum expansion occurs when diaphragm and intercostal muscles relax and air is exhaled forcefully as opposed to the normal passive process. All right, the irregular ventilation, this involves a complex series of receptors and feedback loops. The drive to breathe is based on pH changes in the blood and the cerebral spinal fluid. In healthy people, when the oxygen levels rise, the respiratory center suspends respiration until a rising carbon dioxide level stimulates the respiratory center. So oxygenation occurs by the process of loading oxygen molecules onto the hemoglobin molecules in the bloodstream, and then adequate oxygenation is required for internal respiration to take place. So this is why when we have a hypovolemic episode or shock or some type of bleed, our hemoglobin becomes depleted, so our oxygen carry capability becomes depleted also. All right, metabolism, cell takes energy from the nutrients through a series of chemical processes. Each cell combines nutrients and oxygen and produces energy and waste products. So the process of exchanging oxygen and CO2 occurs and it occurs by diffusion. External respiration is the process of breathing fresh air into the respiratory system, and it helps with the exchange of O2 and CO2 between the alveoli and the blood in the pulmonary capillaries. Then adequate ventilation does not guarantee external respiration. So hemoglobin molecules pick up fresh oxygen as it crosses the alveolar membrane. And then internal respiration is the exchange of oxygen and carbon dioxide between systemic circulatory system and the cells of the body. All right, aerobic metabolism occurs with the presence of oxygen. In the mitochondria, when the cells convert glucose into energy, is the process known as aerobic metabolism. Energy in the form of ATP is produced through Krebs cycle and oxidative phosphorylation. Anaerobic metabolism occurs when oxygen is not present and cannot meet the metabolic demands of the cell. Glycolysis results in less ATP production, and then adequate levels of perfusion and external ventilation must be present for aerobic internal respiration. All right, neurocontrolled respiration originates in the brain and brainstem. It comes from the medulla and the pons area of the brainstem. The medullary respiratory centers control the rate, depth, and rhythm of breathing and a negative feedback interaction with the pons. Okay. This is why when you have damage to that area, a lot of times it results in respiratory arrest. Chemical stimuli, the chemoreceptors modify respiratory rate and depth. It's constantly monitored for the chemical composition of blood fluids. So the central chemoreceptors monitors pH of the cerebrospinal fluid and are located adjacent to the respiratory centers in the medulla. When serum carbon dioxide or hydrogen ions level increase, chemoreceptors stimulate the dorsal and ventral respiratory groups in the medulla to increase respiratory rate. All right, and then continuation dorsal respiratory group is responsible for initiating respiration, and the ventral respiratory group is responsible for motor control of the inspiratory and expiratory muscles. So, disruption of the pulmonary ventilation, oxygenation, and respiration will cause immediate effects on the body. One of the main things it causes is hypoxia. So the tissues and cells do not get enough oxygen. When that hypoxic drive gets stimulated, its oxygen level falls. So it's less sensitive and powerful than the CO2 sensors in the brainstem. And this is typically what happens at end stage COPD. All right, here's some signs and symptoms of early hypoxia. And then here's some of the signs and symptoms of late hypoxia. Okay, so shortness of breath is the medical terms called dyspnea. So this is when we need to get supplemental O2 on board to see if some of these signs and symptoms will correct themselves. Ventilation and perfusion must be matched to exchange gas by simple diffusion. So this is where we get our BQ mismatch. Okay. So failure to match ventilation and perfusion contributes to most abnormalities in oxygen and carbon dioxide exchange. When it's compromised, perfusion continues, but blood passes over some of the alveolar membranes without gas exchange taking place. So this results in inadequate perfusion and less oxygen being absorbed in the bloodstream and less carbon dioxide removal. All right, the interruption of central peripheral nervous systems, hypercapnia, overall increase of carbon dioxide levels in the bloodstream, which could be caused by intrinsic and extrinsic factors. So, but these interruptions in the peripheral nervous systems have an effect on the ability to breathe efficiently. Trauma to the head is one of the leading causes of spinal cord interruption. And we just talked about that coming from the medulla and the pons. angioedema, bronchoconstriction from anaphylaxis could also cause bronchoconstriction. Foreign bodies and trauma are some of your extrinsic factors. So, and when we talk about hyperventilation and hyperventilation, this plays a part in the production. The increase of CO2 not being expelled and it's building up, so the body's not able to eliminate it. Some external factors. So the attachment of carbon monoxide molecules to hemoglobin molecules can cause false pulse oximeter readings, and some internal factors such as reduces surface area for gas exchange in the alveoli, such as pneumonia, pulmonary edema, and COPD. You may have some non-functional alveoli, some intrapulmonary shortening, respirations itself, pain and strong emotions, hypoxia. All right, so circulatory compromise leads to inadequate perfusion, obstruction of blood flow to individual cells, and tissue related to trauma. Some pulmonary embolisms, simple or tension pneumothoraxes, open pneumothoraxes, hemopneumothoraxes, and hemopneumothoraxes could all be some conditions that affect circulatory compromise and respiratory compromise. All right, heart failure, cardiac tamponade has inhibit the ability of the heart to effectively pump. And then you had a hemorrhagic shock, a vasodilatory shock. So we need to be able to treat these patients aggressively so that we can prevent further interruptions of tissue perfusion. Acid base could lead to aspiratory acidosis and alkalosis, and we talked about that in the last chapter, being acidic or alkalotic. So it could slow respirations or speed up respirations, depending on the serum CO2 levels and the hydrogen ions. All right. Also to treat this, being able to increase or decrease respirations, or especially when we're assisting respirations, can help move these hydrogen ions in and out of the body. All right, here's your signs and symptoms as an adequate airway evaluation. The stress may be the result of upper or lower airway obstruction, inadequate ventilation, impairment of the respiratory muscles, or possibly impairment of the nervous system. Okay. So, how's that patient positioned? Do we need to just reposition them? Do we have a supine patient that's laying too far back and maybe gravity's taking effect, and all we really need to do is lift up the stretcher, the head of the stretcher, to alter the force of gravity onto the chest itself? Is that patient sitting in a tripod position because they can't sit up straight to open and expand the lungs itself? Is the patient experiencing orthopnea, where they're positional? Maybe when they stand up or lay flat, their shortness of breath increases. Is there adequate chest rise or fall, or is the patient gasping for air? What's the skin color, and is it moist or clammy? Nasal flares present. Are we breathing through pursed lips? Our COPDers, emphysemas? Do you know any retractions? Is the patient using accessory muscles to breathe? Is the chest wall moving symmetrically? Or is the patient taking a series of quick breaths followed by a prolonged exhalation breath, which is classified as Kussmaul's? And that's usually, your diabetic patients. All right, labor breathing, when a patient's inadequate breathing may appear to be work harder breathing. We see the accessory muscles here right at this point now. All right, inadequate rhythms on respiratory rate 0 to 12, more than 20, not regular rhythm, diminished or absent or noisy auscultated breath sounds, abdominal breathing itself, or the reduced flow of expired air, or inadequate or unequal chest expansion. So increase your effort, shallow depth, skin is pale, cool, cyanotic, blue in color, clammy and moist. Retractions itself are staccato speech patterns where they're trying to speak in between each breath and they're really not getting but a couple of words out at a time. So we need to auscultate the chest wall. Make sure you're doing that anterior and posterior. Feel for air movement and then evaluate for pulses, paradoxes. And then also make sure you get your assessment history while you're going through that. All right, serious hand injuries can have shallow stokes breathing, irregular ineffective respirations that may or may not have identifiable pattern. All right, agonal gasp. So be vigilant when you're dealing with these, and you should be moving straight into some type of airway device, NPA, OPA, maybe a blind insertion airway device if you have that quickly in hand. All right, so let's get that patient's level of consciousness, GCS score. Maybe figure out what their baseline mental status is. The GCS of 15, now we have a GCS of 8. Consider proper oxygenation with assistance when assessing these patients. Do we need to go from a straight to a BBM, or can this patient possibly have an RE breather put in place to help with their respirations? All right, pulse oximetry, please remember that this is just a machine. It's a non-invasive way to tell exactly possibly how much blood is circulating around or how much oxygen is circulating around in the capillary walls. All right. You can use the peak expiratory flow measurement if you have these within your service. That's great. Arterial blood gases analysis, if you're capable of doing this within your service, that's great also. A lot of people don't use this, just because of the blood clotting. Internal CO2, it detects the presence of CO or CO2 in exhaled air. So they may be colorimetric, digital, or digital waveform. This is one of the more aggressive ways that we use it now. Pretty much all patients have some type of entitled CO2 possibly put on that are respiratory compromised. So we have the colorimetric carbon dioxide device detector out there still. Please remember, once you place your advanced airway in, you need to give 6 breaths to make sure that adequate CO2 is coming out when you exhale when assisting those ventilations. Capnographer provides quantitative information by displaying the numeric reading of exhale carbon dioxide levels. All right, waveform provides a graphic representation of exhale carbon dioxide levels. So the waveform capnography provides quantitative and real-time information regarding the patient's exhale carbon dioxide levels. All right, here's the devices that you can use. There's a lot of different specialized classes out there for entitled CO2. Hopefully your waveform looks like this. You got that curvature up to the peak. And then once you start exhaling in that passive movement, it drops and levels back off. All right, don't forget about your head tilt chin lift on your medical patients, or your jaw thrust maneuver on your trauma patients. You may have to open airway for oropharyngeal suctioning, so place the hand on the forehead, making sure that this patient's not going to bite your thumb off. So, and then we have patients that may have to be placed in the recover position, so that we can prevent aspirations. There's your suction devices. Most people have portable suctions, vacuum pressures to help get sputum or vomit out of the airway, so that we can prevent aspiration. And then here's your portable suction device here. Okay, make sure you got soft and rigid suction catheters available. Make sure this machine works when it's not on the charger and plugged in, so that you're not being embarrassed when you arrive on scene and your machine is not functioning properly. Okay, there's your soft tip suction catheters on the right, and then there's your tonsil tip or hard suction catheter on the left. All right, so make sure you check your assembly, make sure it has a pressure of more than 300 millimeters of mercury when it suctions. So you don't want to suction more than 15 seconds for adults, 10 for children, and then 5 for infants. Make sure you have all those parts readily available. A lot of people on the wall mounts, they'll put the hard suction in a tubing right there behind it so that it's readily available whenever you need it. Same thing on the portable suction. A lot of people have it kind of pre-assembled, or at least have all the parts there readily available. So we want to go in without suction. We want to get down to where we feel resistance, and then we apply the suction and come out. All right, make sure that we don't do this longer than 15 seconds. All right, some of your basic airway adjuncts, OPAs there, size differently from the corner of your mouth to the earlobe. Make sure that it's sized perfectly. NPAs from the corner of the earlobe to the tip of the nose. Make sure that we lubricate. Both of these help assist the tongue being moved out of the air way so that we can pass air. All right, severe head injury still listed here with blood draining from the nose. So possibility of a basal skull fracture from trauma, fracture nasal bone. So, all right, there's our O2 cylinders. Make sure the time stamp, month and date, and be in service yearly. So liquid oxygen is cool if you have it. It lasts a long time. So making sure your pressure regulator is attached and correctly attached firmly. Pin index system prevents O2 regulator from being connected to electric, a different gas cylinder. There's your pressure regulators, and there's the portable one and the wall mount. Okay, just some reviewing of how to open up a oxygen regulator or a tank itself. All right, oxygen toxicity is damage. It can cause damage to cellular tissue. So be mindful of that. This is why we've decreased in our respiratory rate and our system ventilations so that we don't cause oxygen toxicity. This is why we've also came out with a standard of for patients around 94, 95%, they may not particularly need supplemental oxygen. All right, your different oxygen delivery devices. Here's your non breather. Please make sure that bag is fully inflated prior to placing that on the patient themselves. There's the nasal prongs if you need them. Partial rebreather mask or the Ventura system. And then tracheostomy mask, which is a way to cover the tracheostomy hole. And it has the strap that goes around the neck. Humidified oxygen here. So a patient who's not breathing needs artificial ventilation, 100% supplemental oxygen. Irregular breathing pattern will also require artificial ventilations. So we can either assist or apply the CPAP itself. All right. Place the mask over the mouth and nose, squeeze the bag each time the patient breathes. After initial 5 to 10 breaths, slowly adjust the rate and deliver appropriate volume. Right, air is drawn into the lungs. There's the blood movement. This is everything that happens during normal ventilation versus positive pressure ventilation. All right, and mouth and mask, physical barrier between the rescuer's mouth and the patient's mouth, and then the bag mask device. Please make sure that that the reservoir is completely inflated, because this is where your O2 is housed. All right, and there's all your different components. Typical adult mask device holds a much larger volume of air than needed. So basically what we want to see when we're doing this is basically the chest rise and fall. We don't need to press this thing all the way down. Once we start seeing chest rise and fall, we can release it to let the patient exhale. We can cause intrathoracic pressure to increase, and this causes more problems than it does good. Make sure if we're using 2-man assist ventilations, that we've got the EC method here being shown, making sure that that mask is at the top. The nose portion bridge is at the nose itself. And so this face piece is also rounded on the bottom to show the chin. So if you're alone, use the EC clamp method. Make sure you observe the gas distension and then changes needed. All right, the flow restricting oxygen devices, we don't see a whole lot of those left out in the field anymore. They were causing too much intrathoracic pressure because we were holding the button down for too long. All right. There's your automatic transport ventilators. If you have those available, we can adjust the ventilatory rate, the tidal volume, and the peak expiratory volume. So if you have one, if it's attached to a long mountain oxygen source, that's great. So you want to set it up, connect the ventilatory package itself. All right, the fitting that attaches to the ventilators a 1522 millimeter fitting. They're pretty standard across the board to all the ventilators. Okay, most models have adjustments for respiratory rate and tidal volume, and then a pressure release valve can result in hyperventilation in patients with poor lung compliance. All right. CPAP is a non-invasive way of providing ventilatory support for patients in respiratory distress. A couple things about CPAP is a continuous pressure, airway pressure device. It continually pushes oxygen into the lungs. These patients need to be alert, able to maintain their airway. If they're in severe respiratory distress, we need to also talk about their history. Possibly COPD. Emphysema patients may not need CPAP right off the bat. We might need to try some bronchodilators possibly first to see if that helps. Some do in the short amount of time that we have these patients, helping those bronchodilators get into the lungs to open up the alveoli may be indicative of that. But they have to be alert and oriented and to be able to maintain their airway. All right, general guidelines, the patient is alert and able to follow commands. Obvious signs of moderate respiratory distress, rapid breathing or rapid distress after submersion incident, or a possible pulse oximeter less than 90%. That's going to be really dependent on your patient presentation and history. Okay, patient unresponsive, these are contraindications, unable to speak or sit up, respiratory arrest or agonal respirations, don't use this stuff. Chest trauma, don't use it. Closing head injury, don't use it. Okay, and cardiogenic shock. Voice tracheostomy, added GI bleeds, recent GI surgery. All right, you can adjust the PEEP on some of these. Cool thing about some of these is we now have the BiPAP capability on some of these CPAPs. So be familiar with those in the device that your agency carries. A lot of patient coaching is done when we use these things. And we'll talk about that with your CHFers. It's usually when we use these CPAPs. All right, if you see gastric distension, more than likely there's some air that has escaped into the stomach itself. That stomach's not going to distend but so far, and then you're going to figure out what they've had once those gastric contents come back up. So be familiar with that. Look for it. Tracheostomies and stomas. If you have a stoma present, a lot of times these patients just need to be suctioned out. They have a plug in there that they can't get rid of, so suction is probably gonna be your number one thing. But if you do have to ventilate these patients, please make sure that you are assessing them for chest rise and fall, and making sure that we have the appropriate device to assist those ventilations. If the tube has become dislodged, if they have an extra tube, please take it with you. And it helps out in the replacement of it. All right, dental appliances, they can come loose, so they just need to be removed. Facial bleeding, you're gonna have your suction ready. So get all that out of the way. And then if you have the foreign body, that completely blocks the airway. All right, here's your King LTD. Hopefully you've been able to put your hands on these at your service. It's pretty much one of the main ones that are carried by a lot of different services. There's many different brands of them or differentiations of them. So be familiar with that. LMAs are still out there some. They're pretty easy. iGels are a little bit more advanced than the LMAs. They're sized, but they self-inflate. So your cover PLAs. I've never used one of these. I've seen them. So they're also a super cloud airway device. Combitudes, I've kind of gone away. There's a lot of different contraindications to these, so you don't see these quite as much. But be familiar with those just in case a service that you go and work with. There's two different tubes there. One, the white one, if you ventilate it and yet it's usually that you place it in the trachea itself, and then the other blue ones you placed it in the esophagus. So you also have to be careful with gastric distension also with these. They have to be between 5 and 7 foot tall, no caustic substances possibly or history of alcoholism. So, all right, we're going to assist these patients. We'll pre-oxygenate. Um, okay. So this version does not talk about or have the intertracheal visualization, intertracheal 2 procedure. It talks about us helping with it. We may have to go back and we'll have to go back and develop a slideshow for that. That's the end of this chapter.